Welcome to Hadassah On Call, New Frontiers in Medicine. I'm your host, Mayan Hoffman. As a mother of 5, with kids ranging in age from 8 to 21, I sometimes wonder if the worrying ever stops. When they're little, you hold your breath as they climb the jungle gym, hoping they don't take a bad fall. But as they get older, at least in my house, it's mountain climbing, bungee jumping, and even skydiving. We're an adventurous family, and thankfully, we've been lucky enough to avoid the ER so far. But I guess it's good to know that if that day comes, God forbid, I have connections at Hadassah. Hadassah Medical Organization's Emergency Department is one of the busiest in Israel, treating tens of thousands of children and adults every year. And when it comes to pediatric emergency care, every second counts. Whether it's a high fever that won't break, a playground accident, or something far more serious, parents often struggle with the question, is this an emergency? Today, we're speaking with Dr. Saar Hashavya, head of the Pediatric Emergency Medicine Department at Hadassah, to get real answers. How do doctors prioritize care in high-stress situations? When should you call an ambulance instead of driving to the hospital? What are the most common emergencies children face? And what role does mental health play in ER cases today? We'll also talk about how the war has impacted emergency medicine, from treating conflict-related injuries to staffing shortages caused by reservists being called up. And of course, we'll hear some incredible stories from inside the ER. Because if you think your family's had close calls, you haven't seen what Dr. Hashavya has. If you're a parent, this is one episode you won't want to miss. So, welcome, Dr. Hashavya.
Oh, thanks for having me here.
Pleasure. Now, the ER here at Hadassah is always full. How do you prioritize care in such a busy environment?
So it's a good question because unlike when you are going to your pediatrician at home and you have the line and you're waiting and your number is 37 and you know that after 37 patients it will be your turn, we use a different sorting system. It's called triage. Basically originated in the battlefield back in the Napoleon Wars when doctors understood that if people with different urgencies will wait the same time in the queue, some of them might die or become in a more dire state of their illness. So basically, we are doing a triage. It means that we accept patients according to their urgency of care. It means that even if you are waiting for half an hour and all of a sudden a child is coming after a severe motor vehicle accident, we will accept him at first. So it's a different way of getting the patients.
No, and that makes sense. Now, as a parent, how would you determine whether or not you should actually bring your child to the emergency department? I mean, I'm a mother of 5, and I sometimes think, well, maybe it's not as bad as I thought. How would you make that determination?
So it's a good question and it's a difficult one to answer. Basically, I will say follow your instinct. I think the mother instincts and the father instincts as well are very accurate. In fact, sometimes when the mother says to me, something is wrong with my child, and even that I am examining him and physiologically everything is fine, I am listening to the mother, we will keep him for observation. And in many times, after a few hours or the time of the observation, we see that something is going on and then we can assess the child. So this is one thing, follow your instincts. Having said that, there are certain rules that we would like people to bring their children to the hospital if they happen. So there is the combination of a non-blanching rash, a rash that even when you try to make it go away from the skin, it's still there in combination with fever. So this is an ominous sign. This is a sign for you to seek medical advice as soon as possible.
Well, the rash tied to the fever.
Yes. Other situations are when there is respiratory distress. We have all sorts of signs of respiratory distress. One of them in children is that we see that all the chest is coming out and inside and out. So this is a sign when the child is breathing too fast. Okay, so this is another sign for us to seek medical advice as quickly as possible. And the other sign is very subtle, but is very important. And this is a change in the child consciousness level. So a child that is very irritable on one side and another child that is very drowsy on the other hand, we would like the child to be assessed as quickly as possible. So those are some points where we would like to see the child as quickly as possible.
So now let's talk about that, seeing the child as quickly as possible and how we get to the emergency room. When is it, or do we know when it's better to take an ambulance as opposed to driving? Because I'm assuming in some situations, every minute counts.
This is true, and once again, we can only give some points where we can order an ambulance rather than coming by car or by bus.
And certainly in this country, when coming by car or bus could take double the time of a normal commute.
Exactly. So when we think that something might deteriorate quickly, we would like the ambulance to come. When we think that if something will deteriorate quickly and we will be in the car, we might get into panic, and it happens a lot. For example, I can only tell you about a story about a child that got stung by bitten by a snake, and the child was virtually okay, was fine. So the parents, which were, by the way, doctors, they took him by car, and unfortunately, while driving in the car, the child started to deteriorate, and eventually we ordered the ambulance to take them from the middle of the way because the father was too upset to drive. So when we suspect that the child is going to deteriorate, we would rather an ambulance taking him rather than his parents or the public transportation.
Now, you mentioned a snake bite. I wouldn't have necessarily come up with that as the first example of something in the ER. So it's interesting. I mean, tell me a little bit about the kinds of challenges that you see. What are generally, if there is a general, do children come in with? What are you treating in the ER?
Oh, so we treat everything basically, and this is one of the interesting or rewarding parts of being an ED physician, that you don't know what your job is going to bring you tomorrow, and even after 20 years, I'm still surprised time by time. So I think it's amazing. Having said that, we have our bread and butter. Um, it divides into medical emergencies like pneumonia, fever, gastroenteritis, diarrhea, and vomiting episodes on one hand, and trauma or surgical emergencies on the other hand, fractures, lacerations, falls, which takes a lot of the patients coming due to fall, motor vehicle accidents. And of course, we have our extremes, which includes resuscitations and children which need urgent medical treatment on one hand, and major trauma, which also needs urgent medical care.
Now, in terms of stories, I know you can't give any details that would make something not anonymous, but are there one or two stories that you can share that maybe even miracle stories where someone's come in some of these very difficult situations and somehow, thanks to your care, have survived?
So I have a lot of stories, of course, after 20 years in the ED. And I would like first to say that the true story is not the one that you are expecting to hear. It's not the glorious stories of saving lives. I know people are more attached to these stories, but it's the everyday life, seeing child in pain and giving him the treatment, and then seeing him going happily home, and when he comes again he's smiling rather than afraid from the emergency department. So I know everybody are expecting to hear the glorious stories. I will share some in a minute, but for me, after 20 years, this is more important to know that the majority of children with minor injuries are getting excellent treatment and are happy to come back. It means that they see us as a safe place rather than a scary place. So this is at first. Having said about those cases that are,
Right, I mean, like Grey's Anatomy, you
yes,
know?
yeah. So
So
I can say that a week a week ago, we had a child coming. We mentioned the non-blanching rash and the fever. So we had a child coming with this non-blanching rash, and we know that he's going to deteriorate. His physician back home already gave us a heads up call that he's sending him in ambulance. So we are now
Bringing it all
putting
together.
it all together. And he did a wonderful job. He's a physician back at home. So we were expecting him, and I must say this is a true emergency. Not many children are getting after it is called meningococcemia. Not many children are staying alive after such an episode. So basically, all the emergency department is ready in the entrance immediately as he came. He was treated. We gave him antibiotics, fluids. He needed already supportive care, which he got, and he basically deteriorated inside the emergency department with the teams of the emergency, the intensive care. Everybody are ready. Everybody are treating him. And after 4 days of intensive care, he went home healthy, and is now back playing soccer at home as if nothing had happened. I would say that another story that is also quite recent and shows I think the miracle of medicine. We had another child actually coming from Mount Scopus, a different section of Hadassah, once again with what we call a septic shock, a bacteria that entered the bloodstream. We gave him the treatment also very promptly. We also put him on inotropes. It means medications that stabilize him, but all in vain. Now sometimes it happens, and even when I was a young doctor, those children were doomed. But today we have the technology, so intensive care here in Hadassah put him on what we call ECMO. I don't know
Yeah,
if
I know it's to help you to be able to breathe. And
yeah, basically it replaced the heart function. And this is truly on the verge of science fiction. So they put the septic child, which in any other scenario would have been dead, on the ECMO. They retrieved him from Mount Scopus to Hadassah and Karim to the intensive care unit. And basically, I can say that 2 days ago he was weaned from ventilation, and he's smiling and happy. He still have a way to go, but this is an amazing story of what medicine can do.
really is an amazing story. And septic shock is something I think that is so scary as a parent because, from what I understand, and correct me if I'm wrong, it can develop from a cut. You can get an infection and it can spread, and next thing you know, you can be in such a deadly situation.
It's true, and this is why we have to be really meticulous when we examine children with fever and to see that we are not missing those signs and symptoms of sepsis.
Sure, and that's a message also I think to pediatricians, all over. No, drugs and alcohol. How much does that factor into what you see in the pediatric ER? Do you have any? Does that lead to people at the younger age coming into the ER?
So Jerusalem, I will switch to Hebrew because we say תשעה קבין של קדושה, 10 קבין של קדושה נפלו על העולם, 9 על ירושלים. So we have our population which we don't see as much drugs and alcohol as other parts of the world. I've been to Australia and to the US, and it's not even it's by factor lower here in Israel, and it's by factor lower here in Jerusalem. So fortunately, it's not a very common problem here. We do get to see them, but it's not a big problem here in Israel.
I guess I'm glad then to live in Jerusalem where we are a little safer and holier, as you described, right, than everyone else. I mean, what about mental health? How is mental health now factoring into the ER?
So unfortunately, in this part, it's not so good. Since the corona and after the 7th of October, we get to see more and more children coming with mental health issues. And we are actually now trying to do a research to see the effect of the 7th of October and of the corona. Of the corona, there are a lot of researches already published, but of all those stressed incidents on the health of on the mental health of the children of Jerusalem. And yeah, I think that we get to see more and more children with mental health problem, both minor and serious. And we need to upgrade or to have more psychiatric experts, pediatric psychiatric experts on the team.
Do these children come in and the mental health also is then impacting their physical health, or are they coming in and needing specifically, as you mentioned, psychiatric support?
So we know that that the health of the child or the adolescent will eventually be the health of the adult in his adult life. So when we get to see the seeds of mental health problems in adolescents, we know that if we won't treat them promptly, it will reflect to all their life, even in terms of non-mental health issues like habits of life, like um, alcohol abuse and so forth.
Sure. And I'm assuming also healthy eating and things like that, which today, spending all the time on the electronics, all of these things are, I see with my own kids impacting them in ways that I'm always saying, get out, exercise, put it down, do this, do that. Let's talk a little bit about adult versus children, because you mentioned how what you do as a child impacts you as an adult. As someone who works in the emergency or runs the emergency department, is there a big difference between treating children versus adults in an ED?
So let me first answer that every time that I need to go to the adult emergency to get something, I will say, thanks God I'm a pediatrician. And yeah, there is a great difference. There is a saying in medicine that the children are not small adults, and I think it's very true. First of all, in terms of the evolution of illness is different, so we need to be more ready for deterioration in children. This is in terms of physiology, but I don't want to speak about physiology. I want to speak about psychology. So children, of course, are very afraid when they come to the emergency department. All their concept of pain is more substantial. And this is why we invest a lot, not in just doing excellent medicine, but also in providing a warm environment in the emergency department. Actually, a lot of our efforts nowadays are invested in making the emergency department as warm and as embracing as possible. For example, we are a pain-free or a painless emergency department. It means that the nurse already in the triage, remember we spoke about the triage, the first moment she sees the child, she give him something for the pain if he's in pain, and she also adjust the medication according to the amount of pain. Also, anxious children, which is perfectly fine to be anxious. You don't have to say to your child anymore, be brave, be strong. No, he can be afraid. We will help him. So if we are doing unpleasant procedures, we are using sedation. There is now 24 hours available sedation services. And once again, we adjust the sedation to the amount of anxiety of the child.
The sedation is not dangerous for the children in any way.
No, so we use sedation protocol and medications which are perfectly safe. Actually, we there is a lot of research that sedation, it's what we call mild sedation. It's not like you are going to theater and they put the tube and intubate you and ventilate you. This is a mild sedation. In many cases, we use what is called conscious sedation. It means that the child is awake, but he is very relaxed. So we have all sorts of new drugs that can help with the sedation. And lastly, but maybe most important, the team is oriented to be affectionate to the child and his family. Sometimes, and it's funny, the child is okay, but his father is creeping out, and we need to treat the father rather rather than the child. The child is holding his father's hand and is telling him, "Father, everything is okay." But you see that the parent is terrified. So we also treat terrified parents. And for example, we have it will sound very funny, but we have a big ice cream refrigerator in the emergency department. I know it's a little bit unhealthy.
That was going to be my next comment.
But sometimes you deserve a treat after you have your stitches being done or your fracture being reduced. So we have even this ice cream refrigerator, and children are basically going happily home.
Well, I now know that when I come to visit Hadassah, that this is where I need to go before I start recording the podcast so that I can get my ice cream fix. Dr. Hashavya, why did you decide to go into this field?
So basically, I started my medical work after I finished my medical training. I thought I would be an internal medicine, an adult physician, and then I my mentor, Professor Engelhardt, asked me if I can go to Ethiopia to volunteer with children. And once treating children in Ethiopia, this is where I decided I'm going to be a pediatrician, a decision I am happy about every day in my life. And yeah, so I came back to Israel and decided to become a pediatrician, did my pediatric residency here at Hadassah. And then I felt that I want to see the extreme of pediatrics. And the extreme of pediatrics is either being an intensive care physician, an emergency medicine physician, or a NICU physician, a neonatal care intensive care unit physician. So I did actually both intensive care and emergency medicine. And yeah, so this is
And the
how,
rest is
and the rest is
history.
history.
20 plus years later. So, what advice can you give to parents, who are thinking about taking care of their kids, keeping them safe to avoid their getting to the emergency room? Do you have any tidbits that you can offer us?
Yeah, I will start with after I mentioned my medical mentor, Professor Engelhardt. I will start with my father, זיכרונו לברכה, and I will switch to Hebrew. He was always saying, "ונזהרתם לנפשותיכם." And this is how I grew up, basically, when my father is like a radar, like he's looking where problems can sprout, can erupt, and taking them away. And I think parents should act that way. See one step in advance. So if you are having your tea and you put this burning hot glass of tea on the table, try to think what your 2-year-old child might do with it. Because, for example, we get to see a lot, too many burn casualties, children, and maybe this is the place to re-emphasize. Even one cup of tea can cause severe burns. We get to see children admitted for weeks just because a cup of tea or a cup of coffee. So I know everybody would like their cup of coffee now. So you can have it, but just if you have small children, think to put it when you are not with the cup in your hand in somewhere safe where the child can't get it. If you have a meicham for Shabbat, try to put it in a place where the child can throw it on himself, and basically just try to monitor your environment and to be safe.
Sure. I remember using my kids are older now, but using the child locks, to keep them out of everything and make sure that they were safe and all the cups on high surfaces. Yeah, we were definitely trained that way. And it's scary to think that parents still, leave a hot water and that a kid can pull onto
I
themselves.
will just I will just say, because we are also in the US, so even small interventions can make a big difference. For example, drowning children, which is a catastrophe. So by the simple act of putting a fence with a lock around private pools, the number of drowning children have decreased by factors. So even small intervention, as you say, putting special locks, putting your drugs in a high place can make an enormous impact.
Yeah, incredible. Have you ever had to treat a child and a parent, or of a parent and child come in from the same family that you've had to see together? Or known that, I know you treat only children, but I mean in the sense that if they came.
So we had a few cases of, first of all, usually when there is, for example, a burn or a car accident, we do not separate the parents from their children. So we get them in the pediatric emergency department.
As opposed to sending them all to the adults.
Yes. So this is a decision that we are not separating children from their parents, unless, of course, that one of them should go to the theater, or but we usually treat them together in the pediatric emergency department. The surgeons will come to treat the adults, and we will treat the children. So we're working in collaboration. So this is one aspect of your question. Uh, we had a few cases where the mother was young and her child was younger. So we actually had few cases where the mother was 17 or even 16, coming with her child. Sometimes they are both sick or having an injury, and we treated them together. It is very uncommon in Israel.
Really uncommon to have young mothers with young children in Israel. I would think in Jerusalem it would be more common.
Yeah, but usually we see they are after the age of 18 getting married, usually, but we get to see some. Yeah.
Here and there, I guess that makes sense. Are there any new advancements in emergency medicine, technologies, or treatments that you're using here at Hadassah?
Yes, so we have several new concepts and technologies. One of the leading concepts that is now already being established is what we call point of care ultrasound. So as you all know, ultrasound is a machine that usually is being used by radiologists, and they are checking your abdomen or your hips or whatever. And for a long time, it was the secret, the field of the radiologist. And when we needed help in assessing the child in terms of imaging, we would ask the radiologist to do the ultrasound. In the past, I think already 20 years, but in Israel, it's in the past 10 years, there is what we call point of care ultrasound. It means that the emergency physicians are using the ultrasound, are being trained to use the ultrasound, and are able to give point of care. It means in real time to give the diagnosis. It is shortening the diagnosis time. It is also make it more accurate because we are knowing what is the question that we want to ask, and then we answer it. And even in a more prosaic way, so even in terms of IV insertion, I'm sure everybody have suffered from when they are going to the emergency department, of putting the IV line and taking the blood drawn. In children, it is much more challenging. The veins are very thin, and sometimes it's very hard. So today we have what is called DIVA, a difficult IV access. And actually, the young residents are using the ultrasound in order to put the IV lines. And I'm now the old one, so I get to see my residents. They are basically maybe 1 year in training, and they are doing it faster than me. Yes. And this is a whole and very exciting field. Other fields in emergency medicine that are evolving, as I said, sedation, conscious sedation. Today, you won't see, when I was a young doctor, sometimes there were five nurses holding the child, and he was shouting. You won't see it today in the emergency department. We have all sorts of sedation treatments that are adjusted to the child's anxiety, and this is a huge difference in the management of children. And yeah, so these are some of the innovations.
And with all of the things that you just named, I know that something that often comes up is an issue with foreign objects. Is that also common in the emergency department?
Oh, yes, yes. A very good question. So we now have actually an epidemic of magnet ingestions. So there are a lot of toys with magnets, and parents and children don't understand the danger of swallowing those little pieces of magnets. Usually they are colorful, so it looks like a candy, and young children are swallowing them. And this is a true emergency. Those small toys, those small bits of magnets can actually cause severe damage. What is happening is that after the child ingests them, the magnet is like a magnet. So two parts of magnet, if he's ingesting them, are getting stuck in the intestine. They can cause a hole in the intestines, and this is lead to a really abdominal catastrophe, really an abdominal emergency. We get to see more and more children that eventually need operation just because of these trivial toys. We are now, because it's becoming an epidemic, we are now even looking not just by asking the parents if the child ingested a magnet, if there is a high suspicion, we actually do an x-ray to see that the child didn't swallow by incident those magnets. On the other hand, when speaking about foreign objects, there is a cultural issue of foreign bodies, that hijab pins. So hijab pins are special pins that young girls and adult Muslim girls are putting in their hijab. And usually, when they put their hijab, they put the needle in their mouth. It's a very common practice. And then, if she really speaks with her mother for a minute, then she might swallow it. Um, and actually, because it's very common here in Jerusalem, here in Israel, we have investigated whether swallowing a hijab pin is different from swallowing any other sharp object. And this is a study which was published in a very important pediatric paper. And we showed that unlike other sharp objects, swallowing a hijab pin, we can manage it conservatively, which means we don't need to operate and to take it out immediately.
Why is that?
So we think that because the hijab pin at the end has this small, how do we call it? So it's sharp on one side, but on the other hand,
There's like a circle or
it's like a circle or something like this. So when the young girl is swallowing it, so usually it goes with the gravity. So the sharp side is usually not the one pointing into the stomach, but rather the other side. So this is one explanation.
super fascinating. So let me ask you one other question, which is about international work. Are you doing any work with Hadassah and other countries or hospitals around the world?
So yeah, it's a great question. So after we have established a very um, busy emergency department and we have enough staff, we are trying to train staff of pediatric emergency physicians in other countries as well. In our own staff, we have specialists in POCUS. We spoke about point of care ultrasound. So we have a specialist in point of care ultrasound. We have a specialist in simulations. So we know how to do simulations of acute illnesses in children. We have a pediatric disaster medicine specialist, which is something quite new. You ask about innovations. So we have a physician that is specifically searching and studying disaster medicine, and we train people in disaster medicine preparedness, and also trauma. So trauma is a very important aspect in our training, and all those specialists are delivering courses in their field of expertise. We have already trained physicians in Ethiopia, in Kenya, around the Middle East, and the program is ongoing both in Europe and in other places in the world.
Amazing. So we're going to get ready to wrap up, but I'm just wondering if you want to share any final thoughts, Anything you wish that parents understood about the emergency department that they maybe don't know?
So I think if we are concluding, I think we will start with your first question. So people should understand that in the emergency department, things are getting done by prioritization, and this is different from other places in the hospital or in their clinics back in the community. So people sometimes find it hard to understand that the line is not going as straight as they would hope it will. So this is on one hand, they should understand that.
I feel like in Israel, people should know that the line never goes straight.
Yeah, so but apart from being Israelis with the line never going straight, so this is a place where it's more chaotic, but usually there is order in the chaos. So somebody is playing this orchestra, even if you don't understand the music. And so this is on one hand. On the other hand, and this is very important to me to emphasize, that here in Hadassah, when you come to the pediatric emergency department, you are coming to a safe place, to a place where they will listen to you and to your child. And we expect it from our team that everybody will feel you and not just treat you as a patient.
Wow. Well, thank you so much for answering all of these questions today.
Thank you very much.